it's clear to everyone in the field of myeloma, of multiple myeloma, that in recent years we've been very pleased, very lucky to be part of the first extremely active, incredibly efficacious immunotherapy called anti-CD38 naive immunotherapy in myeloma. And I think everyone has experienced, and I hope everyone has experienced, how active is this treatment, how it increases the survival of our patients and the control of myeloma with an excellent safety profile. Now, initially, we developed the first-in-class anti-CD38 called daratumumab, and quite rapidly after the daratumumab, we have developed a second immunotherapy called isatuximab. So, of course, the question has become, can we sequence these two immunotherapy? When, for whom, for which patient, in what situation, what is the most appropriate sequence? And since we combine drugs with immunotherapy, what would be then the best combination to apply to patients? It's important also to add to this introduction piece that we use now immunotherapy anti-CD38 upfront, these days daratumumab, but probably at some point isatuximab as well in different combinations. So the question we have discussed in the MyKE session that I've been pleased to share with my two colleagues in 2021 was clearly what data do we have to help our colleagues to better understand how to sequence these two immunotherapy anti-CD38 and what are the options. So what we have discussed during this session was that there are various situations. Number one, the patient has never received anti-CD38. It was very clear to everyone and to my colleagues that then the patient should receive an anti-CD38 in a combination approved according to country's approval very rapidly, as early as possible, and earlier in the disease course and in earlier line as possible. If the patient is exposed in the previous line, particularly upfront, to one of the two anti-CD38, but is not refractory, though there are very limited data, we thought it was fair to say that there is no data to support the use of, again, anti-CD38 treatment in further line down the road, but there was no data to say it was not feasible. And given the fact that in myeloma, we still have patients dying, still patient relapse, and at each subsequent relapse, the prognosis of the patient is getting worse and worse, we thought it was fair to say that reusing an anti-CD38, again, in patients previously exposed non-refractory to the previous anti-CD38 exposure, it was fair to say that reusing the drug was an option and that no recommendation would recommend not to use. Two things. First of all, we thought that you could reuse the same anti-CD38, however, possibly switching was a good pick, a good choice. We also pointed out, we also alluded to the point that it was important, if possible, to change the combination. And finally, it could be still of importance to consider a gap, a time window of at least 6 months, if possible, in between the two exposure of the anti-CD38 monotherapy from one line to the other, to make sure that the previous attachment of the CD38 receptor by the previous anti-CD38 would be released, would be free, and that the two cells would nicely re-express CD38 for the next CD38 treatment exposure to be at full activity, given how it is important for the patients to have the best combination in the relapse setting. Now, the third group, the third situation that did put us into trouble and that globally, I think we disagreed, but we sort of agreed upon, but sort of we disagreed upon, was that if the patient in the previous exposure of the anti-CD38 treatment was refractory to that treatment, the tumor cells did progress while on anti-CD38, whether we could reuse anti-CD38 later on is completely unclear. There is no recommendation. We have no data. And I would even say it's very questionable given the price of these treatments. No, there is no data to say you should not do it. There's one study that kind of say that some of the patients might be retreated with, again, a gap in between the two exposures of anti-CD38 of approximately 6 months and more. But we have no data to clearly say that it's absolutely fine to reuse anti-CD38, although we know that the patient was refractory to that drug, the tumor cells were refractory to that drug previously. So again, 3 situations, very simple: naive, exposure as early as possible; exposed, non-refractory, probably good to go; different combination, maybe switch; and this time window of 6 months and more. Refractory, we don't know. We think it's not a good idea to reuse anti-CD38, but we really don't know. We hope that the soon coming developments with the B-specific CAR-T developments and ADCs and other different immunotherapy that are using different targets, BCMA, GPRC5D, FCFC5, etc., will help us have other drugs, other immunotherapy to rescue the patients when refractory to one of the 2 anti-CD38, so for us not to be in trouble with the question of reusing in that context an anti-CD38. Thank you very much.